Okay, Jo.
Okay, hello everybody. Thank you for joining us today. This is our second webinar on palliative care aimed at staff who are working in nursing and residential homes. Sorry, could everyone else mute? I've just got a bit of an echo. Aimed at staff working in nursing and residential homes or in social care or in hospice at home services. So welcome back. And some of you were with us last week as well when we were talking about advanced care planning. So these webinars are commissioned by Cardiff and Vale Health Board and put on by Cardiff University, and our colleague Charlotte, who is on the call, who has been fantastic in organising them all and sending you all the links and running them all and running the evaluations. So thanks to Charlotte. My name is Dr. Jo Hayes. I'm one of the palliative care consultants based at the Marie Curie Hospice in Penarth, and I work with the community team covering the Vale of Glamorgan. So any of you who are working in nursing homes in the Vale might have seen me at some point. I would sometimes come and see patients. So that is me. Before I hand over to Kat, I'd be really grateful if you asked questions in the chat or make comments in the chat if there's anything you want to say. It's hard for us to see everybody's hands up, but you can put your hand up and I'll come to you if you want to put your camera on and speak and ask a question. You'd be very, very welcome. And it'd be great if it could be a little bit interactive. And then at the end, there'll be a QR code giving you an evaluation. It's really important that we get the evaluations if you would like us to sort of, you know, continue to do the webinars and make sure that we cover the things that you want us to cover, and look at running more in future, really. So without further ado, I'm going to hand over to my colleague, who's Catriona Seed, who's one of the clinical nurse specialists in community palliative care at City Hospice, covering the city of Cardiff. And those of you who work in the Cardiff nursing and residential homes may have met her. So I'm going to hand over, Kat, if that's okay. Kat, you're on mute for me. Sorry. Start
there
again.
We go. Let's try that again. Thank you, Jo. So as Jo said, I'm one of the clinical nurse specialists from City Hospice. So I cover Cardiff. You will be quite familiar with me with some of the nursing homes where I've been doing teaching on recognising, dying and end-of-life care. I'm also one of the new education lead for the hospice. So for today, I wanted to focus on pain control and breathlessness and how we can use opioids to manage these symptoms. So I think, have we got anyone else waiting in the lobby? Charlotte?
Nope, I think everyone is in.
Fab. So we'll make a start. If other people join us, that's absolutely fine. What I would say, as Jo has said, please do put questions in the chat. We really want to get your thoughts, your ideas and your questions. So please stick your hand up or put anything that you have in the chat and we can chat about it. Okay. So hopefully you can all see that screen. Fingers crossed. Oh, hold on. Why is it not moving forward? There we go. So that's Fiona Rawlinson is running late. She'll hopefully join us in a bit. So the general aims and objectives today. So we want to understand how in palliative care we use opioids. You may see different doses and different preparations and maybe you're familiar too. So that's what this is an opportunity to talk through. We want to understand what the different preparations are. You know, there's a lot of different things out there, and when do we use the different preparations? When do we use different doses? So we'll briefly go through some of that, and then we're going to talk a little bit about managing pain with opioids, and then we'll go through a little bit of breathlessness management and a couple of other thoughts that we may want to consider as well. Okay, so I'd like to put this into the chat. Now I can't see the main screen, but it'd be lovely if you could just put some thoughts in the chat that Jo could keep an eye out for. So what kind of things do you commonly see? What are you normally giving your patients? You know, are you giving liquid formulations? Are you giving tablets? What kind of things are you familiar with? Have we got anything in the chat there? I'm asking very quickly.
And while everybody has a chance to just put things quickly in the chat, so I'm sure most of you know this, but with opioids are the strong painkillers that are, well, I'll give you the answer then to the most common one maybe, but morphine is our most common opioid. So we go up with painkillers like step 1 painkillers are things like paracetamol. Step 2 are things like cocodamol, maybe tramadol is sort of somewhere between 2 and 2.5, and then step 3 would be the really strong opioids. Thanks, Kat.
Absolutely. So I've put them in the screen there just to complement what Jo was saying. So you'll often see codeine sometimes in the preparation of paracetamol, so it'd be cocodamol. You can sometimes see a range as little as 8 milligrams of codeine in a tablet, up to the 30 milligrams. And normally that would be a maximum 4 times a day. You do see tramadol. I'm personally not that keen on it. I worked on a medical admissions unit for mainly a female unit, and we'd see these lovely little old ladies becoming quite toxic and tramadol. So I'm not a fan, I must admit, but it does have its uses. The things you'll see very commonly are things like your morphine, so your Ormorph, your Sevrodol. You're going to see something called Actimorph coming through a bit more as well, so I'll go through that in a minute. And then you've got your long-acting preparations. So these typically are slow-release tablets or capsules, which will last for 12 hours. So very good for controlling background pain. Got the same idea with oxycodone. So oxycodone is another opioid within the same family as morphine. We do use it under different circumstances, which I will explain in a little bit. And again, you've got a short-acting preparation, usually a liquid or capsule, and then you've got that long-acting 12-hour tablet as well. And you may see patches. So we often see buprenorphine patches, usually called Butrans, sometimes called Relitrans. They're typically used for stable pain, and then you've got some fentanyl preparations. So we'll look at those a little bit more. So I just popped this in there so people can be familiar with the range of doses that we can use with these drugs. So for morphine, with our short-acting preparation, so ideally when we're giving people a short-acting preparation, if they've got the right dose and it's the right medication for the job, in an ideal world, it's going to last 4 hours. Okay, so that's what we're looking for there. It's going to start working within half an hour to an hour. It's going to last for 4 hours. So most of you will probably be quite familiar with Oromorph, the normal solutions. That's 10 milligrams in 5 mils. Some of you may not be as familiar with the concentrated formula. So for some of our patients that are on very high doses of medications, you may find that actually trying to give that dose as the normal strength of Ormorph, they'd be drinking such big volumes, it wouldn't be manageable. So we then use the concentrated, which is 20 milligrams in a mil. So I'm sure you can understand you have to be quite cautious measuring that one out. And we're quite lucky across the health board now. I think it was last year, Actimorph was allowed to be prescribed across Cardiff. So it's a relatively new formulation, works the same as the Oromorph, but it's an all dispersible tablet. So you can either dissolve it on someone's tongue, or you can dissolve it in a tiny bit of water like you might do the Lanzoxor Fast Tab, and they can drink it. It works in the same way as the Oromorph, but you've got these lovely ranges of strengths. So the 1 milligram we usually use for people with breathlessness, and you range all the way up to the different doses that we would typically use for pain management. And the reason why this is so helpful is for our patients at home, they can't always manage to measure out Oromorph. And the next option we have in a short-acting is Sevrodol tablets, but come in quite big strengths. So having another version of a short-acting preparation that is much more flexible is really helpful for some of our patients. Probably because you're the ones actually giving the medications and preparing them. You'll probably find you won't see Actimorph as much because you're obviously able to measure out the Oromorph. But it's helpful to know that it's out there, because if you have someone transferred to the nursing home from a care setting or from their home setting and they've already been on it, the likelihood is it's going to continue. And like I say, we've got the Severdol tablet. So again, it's just a short-acting morphine tablet, the Severdol, but it only comes in 10, 20 and 50 milligram tablets. And then you've got the long-acting preparations, which I'm hoping you're all quite familiar with. What you may not be familiar with is just how strong the doses can be. So I think you'll probably all be quite comfortable 5, 10, 15, even 30 milligram doses, you know, twice a day. But I looked after someone recently who was regularly taking 240 milligrams of Zomorph twice a day. That's big old doses. So it is important to be aware that actually some of our patients with complex symptoms will be on these higher doses. And then we've got the subcutaneous injections, which you will be familiar with. And we're using those normally 2.5 milligrams to start with, unless they're on another dose of their oral medications. And we generally use those when people can't manage the liquids or the tablets anymore. And then with the oxycodone, it's very similar, not quite as long a list. It's quite a bit simpler. You have got short-acting preparations. I've actually missed one out there. So you've got Oxynom Short-Tec. They're exactly the same. It's just branding. So it's oxycodone. Again, works as the oral morph. It should work within half an hour to an hour. Should hopefully last about 4 hours. It comes in these strengths, and you've got the concentrated, so the 10 milligrams and 1 ml is the oxycodone concentrated. What I forgot to add there is there are Short-Tec immediate release capsules. So that's like the Severdol. We got a slightly lower dose available, so we can get the 5 milligram capsule, which is helpful. It's a shame we don't have that with the Severdol, but they're the 3 things that we've got there. And then the long-acting preparation across Cardiff and the Vale, we generally use Longtec as the 12-hour preparation. So again, that's a tablet that's twice a day. And for some reason, my 5 milligram has disappeared. We've got the milligram, but not the 5. I do apologise for that. But again, you can see we go up to very high doses. So you may see people on some of these much higher doses if their pain requirements have led to that. And then, as again, we have the injectable version of the oxycodone to manage pain or breathlessness when they're no longer able to manage the oral route. Okay. Looking at the buprenorphine patches. So these are patches that are changed regularly. In the lower doses, we usually change that weekly. And some of the higher doses, then they are usually changed every 4 days. So it is important to be aware that if you start seeing, I think it's above 35 microgram per hour patches, you may see that the frequency has changed. Please don't worry about that. That is because of the way the patches are manufactured and how they deliver that pain relief. We normally wouldn't start this. So I'm just going to shut the door a second because that's prepped open. There we go. I'm quite near the entrance, so it gets a bit noisy out there. We usually use buprenorphine patches for people who've got stable pain who maybe can't manage tablets. So often you'll have those for your patients who've maybe moved into the nursing home, that maybe lived home or had family but didn't have someone there that could help them with medications. We shouldn't be using them on someone with unstable pain because they are a slow release patch and we can't respond to their changing pain needs. So it's really important that we're using those patches, we're using it to accommodate for a stabilized pain management. And then we've got fentanyl. So fentanyl is an interesting one. It's a very potent analgesic. It's also very quick acting. So you may be more familiar with the patches, and a 12 microgram patch there you can see is equivalent to a relatively high dose of the oral morphine in 24 hours. They're changed every 3 days. You might see them more often in people with unstable pain. We try to avoid it if we can. But the interesting one I want you to be aware of is Abstral. So Abstral is a sublingual tablet. So that means we're dissolving it in the mouth, just under the tongue. And we use it we call it instant pain. So that's pain that comes on because of something sudden, such as movement. such as they're having personal care, you need to move them in bed, and they get pain on that. We need something that works really quickly in that instance. You know, sometimes a warm off can take 30 minutes to half an hour to act. If someone needs to get to the toilet to go and open their bowels or to pass urine, they may not have that time to wait 30 to 60 minutes. Abstral works within minutes, and then it wears off usually within half an hour. So we only use it for that very short incident, that period of time where we know they're going to have a specific increase in their pain. We only start using it when people are on a minimum of 60 milligrams of oral morphine over the 24 hours, okay? And that's because it's fentanyl based, so it is quite strong. And normally we wouldn't use any more than 4 doses in 24 hours. So it is a little bit, you have to pick your moments sometimes. But particularly those morning washes, I find it really helpful. And if you've got someone who's got quite vulnerable pressure areas, so you're doing regular moving in the day, then it's really valuable medication to use in someone who's got on a lot of morphine and has got a lot of complex pain. Okay. So I just want you to have a think. If you want to put anything into the chat, that's absolutely fine, okay? Think about the common opioids that you're familiar with and think about those doses that you're familiar with. You know, have you come across some of the rarer things that I've just talked about? And think about how you yourself are assessing that person's pain, okay? So it is a common symptom. It is probably one of the most common symptoms in palliative care. It's not just within cancer. It will be for all of our patients, and no matter their diagnosis, at some point will suffer pain. And if you were to look at pain in general, it normally falls into two categories. So you get the acute pain, which is usually related to a specific injury or to a specific disease or inflammation. It's usually shorter acting, and often in the medical term, we talk about acute pain just being over a period of weeks, because then that specific injury or disease episode will then settle down. Whereas chronic pain is often long-standing. It's often related to long-standing disease. It can often be a result of multiple conditions. So if you're adding arthritis to cancer pain, you know, all of those things will escalate that sensation of pain. So when we're thinking of assessing our pain, it's helpful to be able to think about some of the words that I've put here for when you're reporting back to the GPs. You know, when you've got someone and you're concerned about their pain, or you're reporting to the specialist palliative team, you know, just calling up and saying, oh, they've got worsening pain. Actually, what is going on? Because it will affect their pain management. So nociceptive pain is always related to that. There's the two types, somatic and visceral. So somatic refers to specifically pain affecting the bones, the joints, the muscles, and the connective tissues. And it's one they usually can point to really easily. They can say the pain is there. You know, it doesn't tend to move around a lot. They find it often quite easy to describe. They often use the words like, oh, it's a dull ache, or it's a sharp pain, or a stabbing pain. It's an easy pain to localize to, that they can often say, it's here, it's here. And it can be a pain that's worse on movement, particularly if it's located in the bones or in the joints. Whilst visceral is organ, it's pain related to the organs, and this is often really difficult to localize. It often moves, so we talk about referred pain. So someone could have the source of pain in the stomach and feel pain in the shoulder, which doesn't feel like it should make sense. But it's part of how the body then, how the nerve endings and things are transferring that sensation of pain. But it is really difficult for some people to describe. Some of the common phrases are crampy, dull ache, and things like that. But some people just, they cannot put a word to it. They just say, I've got pain, which is very understandable. And then you've got that neuropathic, so that's specific damage to the nervous system or a dysfunction in the nervous system. And again, this is one that's very difficult to describe, but some of the more common words that you will hear will be numb, burning, tingling, stabbing, and you'll find that they can often localize where it starts, but it moves. So they say, oh, it starts on my back and then it radiates, or it moves around to the front of my ribs. There'll often be that movement. It starts on my hip and it goes down my leg. So you'll notice that there'll be a difference rather than the pain staying in one place. Okay, so when as healthcare professionals we're thinking about our pain, this is a really good thing to think of, okay? If I'm going to follow Bill and Ted, I'm going to say Socrates or Socrates. So we think about where the location is, where are they describing the pain, where is the site? What is causing it? So it's starting, when is it starting? You know, is it starting after movement? Is it starting and then lasting for a long period of time? What is that onset? You know, there are particular times of day that the pain comes. What is the character of the pain? So can they use any of those descriptive terms to help us identify perhaps what is causing the pain and what medications might be helpful? And is there that radiation aspect? So is the pain moving from one location and it's moving around to another part of the body? It's helpful to think about any other associated factors. So is it worse at certain times? And sometimes that might be they get worsening pain when they're breathless. They might get worsening pain when they're constipated or pain on eating. Is there something else that is either precipitating the pain or that they're noticing? Some people will feel nauseated when they've got pain. It's quite common. Other people might feel quite anxious when they've got pain as well. So it's important to look at the whole picture and then looking at the timing. So when is it starting? How long is it going for? Is it continuous pain, or is it something that just seems to last for a certain period of time? And what are we doing to relieve it? Is it about repositioning? Is it about using certain medications? Do they like a hot water bottle? You know, thinking of those other factors that may help to relieve that pain and also may make things worse. And severity. Now it's quite nice, I think, on the next slide. So if someone's got capacity, you know, we can ask them to give us a score, 0 to 10. So 0 being no pain at all, and 10 being the worst pain that they can imagine. Some people can find that quite difficult. Sometimes there's the VR, so that's called the numerical rating system, or NRS. There is a visual rating system, VRS, and that's like a series of pictures. And you can almost show that to someone and just get them to point, say, that's how I'm feeling. And sometimes they find that a bit easier. But we've also got for our patients who are either non-verbal, or you know, they've got cognitive impairment to the point where they cannot accurately vocalize effectively to say that they've got needs and cannot express their needs. So we have got the Abbey Pain Scale, and I hope you're all very familiar with this. So we look at what's happening with this person. Are they making any vocalizing noises? Are they groaning? Are they whimpering? You know, are they making facial expressions? Are they frowning? Are they grimacing? Are they holding themselves, holding a part of their body, you know, guarding or protecting it? You know, for those that have got reduced cognition, are we seeing behavioural changes? Are they getting aggressive? Are they shouting out? Maybe there's someone when they have pain that they withdraw and they become very within themselves. You know, looking for things like low moods and things like that. And that's where can be really helpful. So obviously you would score them and then you would give the medication. You would assess whether it was a mild pain to a severe pain, and obviously then manage that as appropriate. There's another one. You're going to behave. There we go. There's another pain assessment tool which I quite like, which was designed in advanced dementia. And that again is a little bit of a simpler version of the Abbey Pain Scale. So it's looking at some of the common visual or psychological change, physiological changes, I should say, that we may see when someone's got pain. So for example, breathing, we may notice that their breathing is getting quite rapid. we will sometimes find that less in very chronic pain, in all honesty, because people get accustomed to the pain. So for things like breathing, you may notice that less, but there is a chance that you could see that if someone's got an acute change in their pain. Again, like with the Abbey Pain Scale, we've got that vocalization, we've got that moaning, that groaning, those distressed noises that they may be making. We may be seeing them making, those frightened or those distressed facial expressions, particularly when they start really kind of pinching around here. I would certainly be alarmed and think someone's either pain or agitated at that point. And then looking at their body language and looking about, there's a really nice point at the bottom of this one about consolability, and where they're actually, giving reassurance, repositioning someone, just talking to them, holding their hand. Is that enough? Are they actually just got a little bit of distress or agitation? Is that enough? Or actually, are they at a point where doing that is going to cause them more distress, or they just can't respond to it at all? And in those situations, it is more likely that there is pain that needs to be addressed. Okay. I just wanted to show you this brief diagram as well. So this is really interesting. So this was a phrase coined by Dame Cicely Saunders, who's responsible for the modern palliative movement and the modern hospice movement. And she talked about this idea of total pain. So pain isn't just about that physical symptom. It's not just about pain due to their disease or their physical decline. There is a full holistic aspect to their pain and often other symptoms, in all honesty. And sometimes when we're assessing people's pain, we actually need to think about these other aspects. So if you've got one of your residents that has got complex pain, that has suddenly, well, they haven't got complex pain, they were quite comfortable. And, you come in one day, you've been off for a week, and you come in and you think, oh my goodness, what's going on? They're in so much pain. They're needing all this extra OMOV. And then you discover that actually their spouse just died. So they can't interpret that. When we've got intense emotions, other negative stimuli are going to feel worse. So pain is going to be much more intense. Any other negative symptoms are going to be much more intense. Maybe they've just moved to the nursing home and they're struggling to come to terms with the fact that maybe they were fully independent in their own home. Their life has changed, their own health has changed, and now they don't have full autonomy over their lives. That can make a huge difference to people. So it's really helpful to have a little look at that, get familiar with these concepts, because it is fascinating how often we can address pain by looking at all of the aspects, the social aspects, those spiritual aspects, and psychological, and not just focus on the physical side of things. So when we're managing people's pain, as Jo said, we follow the WHO analgesic ladder, which has been around for donkeys. There's a new version that's out, which hasn't changed a huge amount. So we generally start with things like paracetamol, and then if we're pain starting to step up, we'll usually move on to something like codeine. So I've put a little aside there because I'm not a fan of codeine. I find people respond differently to codeine. There's a little bit more variability in the population as to how people respond to it. And some people do not like moving on to morphine because they're scared of taking morphine. As you can see there, 2 30-milligram tablets taken 4 times a day is already equivalent to taking 24 milligrams of morphine. So when I'm sat with patients and I'm explaining that actually, for whatever reason, we're considering changing them from codeine to morphine, and explain to them they are already in effect taking the equivalent to 24 milligrams of morphine, they're less intimidated by it. So it's a helpful thing to be aware of. I tend to find codeine is just more constipating as well, which is always quite surprising. But I tend to, if I can avoid it, I would rather just start a low dose morphine, and that's a personal choice there. But morphine will be the first choice for the moderate to severe pain. So that's looking at that 2.5 on that analgesic ladder and step 3. We always start, this would be the same for oxycodone, we always start on an immediate release solution first, or the tablet. And the reason for that is we need to find out what dose is going to work for that person and how they're responding to it. So normally for pain, with morphine, we would start at 2.5 mils, which is equivalent to 5 milligrams. And normally we would suggest up to 4 hourly, and that's because that's how long it should work as a successful analgesic. And they could have that as they needed. And then we would look at how much they are needing over a period of time, and consider then if they're needing quite a lot of the immediate release, then we could look at starting the modified release, that long-acting tablet. If you've got quite frail or elderly patients and they're new to something like morphine, we would often start them on a slightly smaller dose. You might see something like 1.25, which is equivalent to 2.5 milligrams, just because, again, they're often more slight and they're often more likely to be underweight. They may have kidneys that are okay, but maybe not quite at full function. And again, we'd rather start low, build up, than start on too high a dose that they have side effects from, and then they will never try that medication again. If we are starting a long release tablet, it's really important that we make sure they still have access to that Ormorph or the Actimorph or the Cefridor, that immediate release morphine, and we use it for any pain that they may have on top of that long release tablet. Now, remember, so when you see some of the larger doses of the morphine sulfate tablet, the MST, the Zomorph, and then the oxycodone, the Long-Tech, if you see, say, for example, 15 milligrams of MST, so that's equivalent to 30 milligrams of morphine over 24 hours, you would expect their immediate release morphine to be 5 milligrams, because that is 1/6, okay? And as their morphine requirements go up, as they start needing more and more of the modified release dose, we would need to step up that immediate release morphine. So it always stays kind of in line with the total morphine dose that they're requiring. Otherwise, we'll give them that immediate release morphine dose and it won't be enough, it won't work, and then they'll just be distressed. So I've covered quite a lot of this already. We generally use more oxycodone for people who can't tolerate morphine. So those are patients who maybe have unpleasant side effects. Sometimes it's because they don't actually respond to morphine. So morphine and oxycodone hit slightly different pain receptors. And sometimes if we've tried someone on morphine and we're escalating up the doses and we're not finding much of a benefit, actually sometimes trialing oxycodone and seeing if that's helpful has a good impact. So sometimes it is for that cause as well. But we also use oxycodone if there's any renal impairment. So we look at a number called the eGFR, which is an indication of how well the kidneys are filtrating any toxins and everything in the blood. And if that starts getting below sort of 60, we start thinking, shall we get some oxycodone in? But we use it in exactly the same way. Now, and I'm hoping some of you will have picked up. So we use 2.5 milligrams, which is in 2.5 mils. In the Oromorph, we use 2.5 mils, which is equivalent to 5 milligrams. The reason for that is oxycodone is twice as strong as morphine. So if you're swapping someone over from morphine to oxycodone, you will always see a drop in the actual quantities that they are getting, because oxycodone is stronger. Okay. And again, like with the Oromorph, in lower doses, we would normally start lower again. So we might start at 1 milligram, 1 mil, and titrate up as necessary. And again, with the modified release tablets, we always have the immediate release oxycodone, whether it's Oxynorm or Short-Tech, available. And we do the 1/6 as well. So everything works exactly the same between the morphine and the oxycodone. It is just whether someone can tolerate one or the other. Okay. And then I think as well, it's worth noting, in case, you see something that's maybe been done, maybe the GP's gone out, it's worth being aware that yes, oxycodone is twice as strong as morphine, but people can respond to opioids differently. And some people can find that they found morphine less effective and they respond really well to oxycodone. To prevent opioid toxicity, we would normally, whenever we titrate someone from one type of opioid to another, we usually take a step down. We always warn people then we might need a bit of extra of the immediate release medication for the breakthrough pain. And we would keep an eye on how often they're needing it. And then we would titrate to that long acting accordingly. But it's always safer to go lower and go back up on a dose than it is to give someone too much and risk them having a negative effect. Was there anything you wanted to add, Jo, yet?
So not particularly at this point, Kat. I'm listening
No,
closely and manning the chat.
Perfect. Thank
so
you.
in the chat, there just is one comment from someone that says they're using subcut diamorphine. Really sorry to single people out. I won't say her name here. It's in the chat. And I was just asking where that person was working, because our understanding is that within Cardiff and the Vale, we probably should all be using morphine unless there was some issue with availability. And they're not exactly the same thing. You can't just swap from one to the other and keep the same dose because they've got slightly different strengths. So it would be useful. Yeah, it'd be useful to know where you're working, the person who's using diamorphine, and maybe that's an area that you're using diamorphine more. I should have said at the start, really, that Kat and I are working Cardiff and Vale.
Yeah, and that's something we can pick up in the questions after. So, because it is interesting that when we have seen diamorphine, I just want to quickly just say about the Abstral fentanyl sublingual tablets. You will not see these very often in all honesty. I've probably, since I've been working in the community, just over 5.5 years, I've probably used them on patients probably less than 5 times, in all honesty. But it can be really helpful, particularly for people who've got significant pain or movement. For some of particularly our cancer patients, they can develop what we call pathological fractures. So that's a fracture where there hasn't been a traumatic incident and the bone has just broken because it has become so weak. And those people can have really intense pain or movement, and this medication is really helpful. So like I mentioned before, it's really good for helping with personal care and for when people are maybe mobilised into the bathroom. We want it for that short incident because it starts to work really quickly and we normally wear off within 30 minutes. So if someone's got a longer background pain, breakthrough pain, we're going to look to want to use the Ormorph or the Oxynorm liquid. We always start on the lowest dose, doesn't matter what dose of background pain relief they're already on. We always start on 100 microgram tablets and then we would titrate up according to the need, how they respond to it. And obviously no more than the 4 doses. And then we've got the subcutaneous. I'm not going to go into this in detail because, to be honest, we usually use these when people are coming towards the end of their life. And we're going to cover that in a bit more detail on our session in December. Okay. I just wanted to give an example of some of these medications and some of the doses that you may find you're less familiar with. So we've got Colin. He's a 79-year-old man. He's living in a nursing home and he's got lung cancer and he's unfortunately it's spread to his bones. He's got back pain, which has been long-standing, and he's been taking his MST 30 milligrams for a long time, and that's working really nicely. So, he has his Ormorph dose. So if you see there, we've got our 5 mils, which is 10 milligrams. So if we take our MST 30 milligrams twice a day, that's 60. Divided by 6, we get our 10 milligrams. So that's our appropriate dose for the breakthrough pain. But he's only just needing it occasionally. But you come in, you've just come in into the shift and you've discovered, you've been off a few days and you found actually he's needing it every day. He's still complaining of pain despite having 3 or 4 doses of the Ormorph every day. And it's so severe, he's very distressed. He can't even get out of the bed because he's so much pain. So what do we need to think about? So we know pain is multifactorial. So what has happened? Has he had a fall? Has there been any other acute events? Are there any other factors that are going on here? Has he had some bad news? Has there been a death in the family, or is there something else that's really worrying him? We know he's got cancer. We know that would be progressive. And has there been a natural progression of his disease that has led to a sudden change? Maybe his families have gone away. Maybe they visit quite frequently and now they're not there. So there could be all sorts of things that we may want to be thinking about. Okay, so we really need to get him reviewed. We need to get him reviewed by the GP or the community specialist palliative team if they are involved. Okay, and they'll do the pain assessment as well and look for those potential causes. Now, if he's had a fall, in your documentation, and Karen covered this in the advanced care planning talk, some people may not want to go into hospital even if they had a fracture. They would rather just be comfortable at home. If they've had a fall, and they would consider having that x-rayed to help us decide how we're going to manage pain. Do we need to consider sending them to A&E? But with pathological fractures such as can occur with people with cancer diagnoses, and particularly when they've got cancer that's entered the bone, they may not always have had a sudden event like a fall. One of my patients who was living at home developed a pathological fracture because their daughter was helping them put on their knickers, and she just moved her leg slightly awkwardly and heard a crack and then had intense pain. So it could sometimes be such a minor event that you would not think that you've actually broken a bone. And obviously look at, talk with family as well, and look at any advanced care plan documentation that you may have done. Now, with the immediate release morphine as well, we say it lasts 4 hours. But in palliative care, we do appreciate sometimes when people have a very acute change in their pain, they may need it more frequently to manage their pain. So please don't be alarmed if someone is saying to you, you can give it up to 2 hours for pain management, because if someone's had a significant change in their pain, we need to get on top of it, and we need to discover just how much medication they need to manage that pain. Now, this gentleman does go into A&E for an x-ray, and he has been found to have a pathological fracture to his hip. He's still got the severe pain. He's sent back home. So they have increased his pain relief. So we've gone up to MST to 45 milligrams twice a day. So that, again, if we break that down, so that's 90 milligrams in total MST in the 24 hours. So 90 divided by 6 is equal to the 15. So that's 7.5 mils, 15 milligrams. And they have suggested, yes, he can have it up to every 2 hours if he's got complex pain. And they've also suggested the Abstral for the instant pain. And that starting at the 100 micrograms. And the palliative team say, yep, great, we're getting those changes in place. We'll give you a call in a couple of days later. Okay. We'll go back 2 days later, and that background pain is much better, which is fantastic. So on the whole, his pain is much better. But when he's trying to mobilise and go to the toilet, when he's trying to roll in the bed, he's still got that significant pain, and it doesn't seem to be improving. So the palliative nurse is chatting with the staff, and they're not familiar with Abstral. It's not something they use. They've got the Oromorph. That is a great pain relief. They know it works well. So they've been giving him the Oromorph prior to the wash. They had tried the Abstral, and it was used just a bit early. And it's really hard, isn't it? And on the wards, in the hospice, in nursing homes, you give someone medication, you go, we're going to do this task now, and someone goes, sorry, this is really urgent. Can you go off and do this thing really quickly? It's happened to all of us. But they've tried the Abstral. They have decided not to give it anymore because they tried it. He had an hour for his wash, and it wore off before he had a chance then to have his wash. It's one of those things that is so easy to happen. But if we're going to use Abstral, we need to use it pretty much minutes before we do the event. Okay, so we need to be really prepared. We need to be fully prepared to do the activity before it's given. Whilst with the Oromorph, we would do that, wouldn't we? We'd go off, we'd give the Oromorph, we'd go away, we'd give it a chance to work, and then we would go back and do that activity. And that's something that's really important to be aware. If you ever come across Alpstra, you've ever got someone on it, you should have the palliative team involved, in all honesty, because it is a rare medication to use in the community. And please ask questions, and please make sure that everyone is happy with using it, because when it works well, it's a really fantastic medication to have access to. And then I am aware of time. We're just going to do a little snapshot on managing breathlessness.
I was just going to say, it sometimes you can't. I was just going to say you can't always calculate the dose of Abstral in the same way that you can with morphine, and so it doesn't work. As well as the timing that you're giving it, we sometimes need more of a dose. Sometimes need to increase the dose, but your palliative care team would be involved in that. And some of the palliative care patients are at risk of fractures. It doesn't have to be a fall. If someone's got severe pain, exactly as Kat said, we should ask for them to be reviewed either by their GP or by their palliative care team, unless they have had a fall or are in huge discomfort, though it doesn't necessarily mean sort of dialing 999 or anything. It's usually okay to just ask for a review from, GP or nurses, or sometimes the palliative care doctors who are working with the teams. Thanks,
absolutely.
Kat. And it's 17 minutes past. I know you know the time. Sorry, I just
no, thank you. So we're just going to chat briefly through management of breathlessness as well. So you will see us using opioids for breathlessness. So it is a very subjective experience. Someone may feel breathless and they're able to talk to you quite comfortably, but they will feel uncomfortable with their breathing. And we find it often presents initially as breathlessness when they're doing activities, so maybe walking around, walking to the bathroom, and they're getting very breathless. But a lot of our patients, as they're deteriorating and getting more frail, they will become more breathless at first. My goodness, there's a gale going on out there. And we do find it makes a huge difference to their quality of life over time. It's quite a frightening experience. People often feel very anxious, which can make that sensation of breathlessness worse. And we tend to find they just get more frail just because they can't do as much because of that breathlessness. It is very common. Okay, so a lot of our patients with all sorts of disorders suffer from breathlessness. Obviously, cancer is a common one, but obviously COPD, heart failure, renal disease. There are lots of causes for breathlessness out there. So I want you really to think about some of the things as the pain. So you could almost, we won't be looking for sight because we know where the lungs are. But we want to be thinking about the same thing. When is it happening? Is it continuous or is it short bursts of breathlessness? Do they have associated symptoms? With the breathlessness, are they having pain? Are they having chest tightness? Are they having hemoptysis? Or are they bringing up streaks of blood? Or are they bringing up fresh blood? All of these things will make a difference and help us triage and work out what we need to do for our patients. Oxygen readings can tell us something, but they can't tell us everything. There are plenty of people with COPD that will get very breathless on exertion and their oxygen levels will be perfect. So it doesn't always give a true reading. And then looking at those exacerbating relieving factors, looking at what ground anxiety and depression they may have that may be worsening things, and anything else that may be going on. Obviously, looking at people's ACP, as Karen has said, we're not going to want to send people into hospital if that's something that they don't want. And we don't want to do tests on people if it's not going to change what we're going to do. But there are other tests that are available depending on someone's diagnosis, the severity of breathing and their condition. So they are things that we should bear in mind, and the GP may go through those. And with anything, we always want to reverse those reversible causes. Okay, so things like infection, things like low oxygen levels. So do they need to have home oxygen, which can be organised through the GP? Do they have low blood levels? Do we need to send them in to have a blood transfusion? SVCO, I'm not going to go into that here. That is very rare. That is a particular palliative emergency related to lung cancer, where there's an obstruction of the superior vena cava causing blood flow to not be released from basically here up. It causes the equivalent of fluid overload in the lungs, leading to a lot of significant breathlessness. If you've got someone with lung cancer who's at risk of it, the palliative team will be involved and we will tell you the warning signs. So I'm not going to go into that for you now. PE, so your blood clot on the chest, do we need to get them sent in to get that treated? Are they going to need to have your clexane injections or another anticoagulant to keep on top of that? Looking at any of the effusions in the chest, your pericardial, your pleural ascites. Yeah, I know that's abdominal, and it is amazing sometimes that you think about it. We are a closed cavity space, aren't we, in the whole of the chest area. So if you've got a very swollen tummy, either because you're extremely constipated and you're obstructed, or because you've got a lot of disease in your tummy, or a lot of fluid, such as ascites, that's going to mean that the diaphragm can't work sufficiently, which is then going to make you breathless. So if we can manage any of those things to make that breathlessness more manageable, it's going to make that person feel more comfortable. Okay. One of the things that we do to make people feel more comfortable with their breathlessness is we don't always reach for medication first. So we usually use things like fan therapies. So you can get the little handheld fans, as well as the normal ones that would sit on the table or on the bedside. And with the fans, it's really helpful to have them about here, about 10, 15 centimetres away from the face. And the reason for that is we've got skin receptors just under the skin, just above on this lip, under the nose. And that basically communicates with the respiratory part of the brain to say, hold on a second, we're getting air. Calm things down, there is air coming. And it's amazing how often something simple as that can make that sensation of breathlessness feel more comfortable. Positioning is really important, so sitting people up. If there's someone who's bedbound and they're always lying in the bed, always make sure that bed's always at a minimum of 30 degrees, propping up those pillows so they're comfortable and those shoulder muscles are supported to help aid that breathing. And for those that are still mobile, we're going to look at how we can support them with energy conservation so they're not getting too exhausted. So helping them with maybe their washing and dressing, so they're not feeling as breathless from it. Make sure they've got access to things like sticks or frames to help them mobilize. So again, they're not getting as tired when they're moving. And there's complementary therapies out there that can be really helpful. So thinking about things like the reflexology, the acupunctures, and even aromatherapy can be really helpful as well. Things that might just help them feel a bit more relaxed. Counselling could be really helpful as well. Just thinking about that anxiety element, is there something else going on in their life? And then managing that breathlessness with the opioids. So again, morphine is our gold standard. We do use oxycodone for the same reason as in pain, because someone hasn't tolerated morphine or because their kidney function is poorer. So we want to be being a bit more cautious. The starting dose is 1.25 for breathlessness in morphine. So you can see we use that slightly lower dose. And we often find with our patients who are breathless, we know there are standard times that they're always going to be breathless. And the classics are their morning wash, or having a shower, and sometimes even their meal times. So eating and drinking may be their regular meals, they get very breathless. So sometimes what we might suggest is taking the morphine maybe 20 minutes, half an hour before that predictable task. And what it would do is it relax the breathing down. It won't completely resolve the breathlessness. They will still have an element of breathlessness, but it will hopefully make things more comfortable. If someone's needing a fair few doses of that morphine and it's working really well for their breathlessness, sometimes we might consider a low dose of that long release morphine tablet in the background, just to help with that ongoing breathlessness. There's some other medicines to be aware of as well, and I won't go into detail with these, but it is important to be aware that there are other options to help with breathlessness, particularly the benzodiazepines. We tend to use them in caution in palliative care, but if someone has got an anxiety-related element to their breathlessness, we can find them quite helpful. For people who've got low mood as well, and an anxiety-related element to the low mood, then some of the antidepressants, particularly things like mirtazapine, can be helpful. And we can get oxygen. Now, there is poor evidence for oxygen in breathlessness in general, unless someone has got significantly low oxygen levels or whose oxygen levels drop when they're mobilising. We will sometimes use it then. And again, we need to make sure that we're getting that through the GP. So for people in the community, the GP has to do a HOOF form, which is home oxygen applications, and they're able to get that. And hopefully no one's smoking in the nursing home, so that should be fine. And again, I've put this here, but we're going to cover this in much more detail in the session in December. But when someone has breathlessness at end of life, we do want to keep on top of that. We will always make sure they've got the morphine or oxycodone available for the opioid side of things. The midazolam will, in effect, be the equivalent of lorazepam, diazepam to help that anti-anxiety medication. For those that develop those noisy secretions towards the end of life, if they're distressed by it, again, we can use those anti-secretory medications. Good positioning, good mouth care is also important. And just a little note, again, if anyone is ever on a pain patch, and then we're starting to use injectable medications at end of life, please don't take it off. It must stay in place, because if we take it off, that lovely pain relief that has been given is going to be taken away, and we're going to end up with a sudden increase in pain. So really important to just continue to change that as it was prescribed. And that was quite a lot for you guys to go through. Are there any questions? You did well through all of that.
Thank you very much, Kat. We've had a few questions in the chat, but not necessarily specific. And we've asked for people asking for the slides, and I have signposted people to the YouTube channel where the recordings will be uploaded within the next few days. So you'll be able to not only see the slides, but hear Kat and see her talking all the way again.
You could put me on mute if you want. I won't be offended.
Does anybody want to put any questions in the chat? Anything at all? You have us here, and we're happy to answer or comment. I'm guessing it's not always easy there if you're, you know, the only nurse looking after a floor in a nursing home and somebody's in pain. So anything that you want to share or that you find tricky, you know, very happy to discuss. Good. Some people saying that they feel more confident with this type of medicine.
Good. Oh, that's lovely.
Thank
I think
you.
It's one of those things that I remember.
Well, sorry, go on, Kat.
Yes, I was going to say, I remember how nervous I was with morphine when I first qualified. And when I went into palliative care, we started using doses that I'd never seen before, you know, and it can feel quite intimidating sometimes, but it's just that reassurance that actually if someone's taken these things regularly, these numbers will make sense. And if you're ever unsure, you just speak to someone. You know, if they're known to the palliative team, ask them, get them to talk through things with you, because I find the way I work, if I talk through things, it makes much more sense to me. So, you know, and if you've got anyone who's got these acute symptoms, then please get these people reviewed and make sure that you're getting the right support as well.
Yes, completely. So anybody that's got any queries, your local palliative care team, even if the patient is not known to them, won't mind being called and running through any concerns or queries that you have got, because we're all here to help. Out of hours, there is palliative care advice available through the GP out of hours service, or if needed through Cardiff and Vale switchboard.
So hopefully you've all seen the QR code for the evaluation. If you are able to complete that for us, that would be lovely. Because obviously any feedback will just help us improve and develop our sessions. And I think the next one, we've got a little break now, haven't we, Jo?
I think we have. Just let me check my diary. Or if Charlotte's there, she probably knows.
Yeah. So
Let's
the next
have
one is the
a look.
30th November, and I've popped the link in the chat. If anybody hasn't signed up to that one, they can just follow the link and sign up.
Brilliant.
Fantastic. So we'll hopefully see you on the 30th of November. Thank you very much,
Lovely.
everybody.